connected. We are happy to see you all again, and we are excited to have our spotlight today on a new technology for DBS and our fantastic speaker, Dr. Ponce. So before we get started, my name is Anissa Mitchell with PMD Alliance, in case you've not seen me before. And I'm just going to point out a couple of features on Zoom. First of all, we are going to invite you to ask questions today. So if you could hover over to the bottom of your screen, at the bottom, you'll see a toolbar and there is a little box that says chat. If you want to click that open, and then you can chat your questions to us. And at the end of the presentation, then we'll go back through those. And there is an option if you like live transcription. You can enable that by the live transcription button, and you can either enable or hide the subtitles. You can also move them around the screen so you can place them in different places. I know there's going to be slides, so you can always move them over to the side so they're not in the way. And if you want to give a shout out and let us know where everyone is joining us from, we would love to see where everyone is coming to us today from. And I'm from Orlando, Florida. So let's see if we have any other Floridians out there. So I'm going to introduce our speaker. We have Dr. Francisco Ponce. He is a board certified neurosurgeon serving as director of the Center for Neuromodulation and Neurosurgery residency program. And he's chief of stereotactic and functional neurosurgery at Barrow Neurological Institute in Phoenix, Arizona. He completed his neurosurgery residency at Barrow and a fellowship in stereotactic and functional neurosurgery at the University of Toronto in Ontario, Canada. His expertise includes deep brain stimulation and surgery for Parkinson's disease, essential tremor, and dystonia. So he's going to be talking to us about Medtronic's new BrainSense technology today. So welcome, Dr. Ponce.
Great, thank you. I'm going to share my screen now.
Yep, go for it.
All right, let's see. And start slideshow. All right, let's see wrong one. Let's see. Stop sharing. Share screen. This one. Okay. Okay, how's that? Are we good? Great. Okay, so I'm Francisco Ponce. I'm a neurosurgeon. I do a lot of deep brain stimulation, and I'm going to talk about advanced control and understanding of Parkinson's with BrainSense DBS. I think there's a lot in that title. I think it's exciting because there's features of this therapy that's not just administering the therapy. It actually has a window to have a better understanding of your disease state, of what's going on day to day, hour to hour with patients' Parkinson's disease in a way that we've really relied upon crude measures like patient diaries, people having to record where they are at a given time during the day and when they're taking their medication, a way to really document this. I think that's exciting. Also, the future options that are made available through the current technology. I do consulting for both Medtronic and for Boston Scientific. I don't get paid for this talk, so just because I'm giving a talk about the new Medtronic and I work with them, I think that would be a disclaimer. I always say, I've been giving talks about this for over a decade now, and the way to think about DBS is that it's a pacemaker for the brain, right? It's an electrical therapy. If you think about a heart pacemaker, right, it goes in the similar location and the leads go to the heart. We're using it to correct abnormal brain rhythms. And similarly, we use deep brain stimulation to correct abnormal brain rhythms, heart rhythms versus brain rhythms. And the tool is really a tool that is used in the neurologist's office. The neurologist is the one who turns it on. The neurologist is the one who makes the adjustments in conjunction with changes with medication. So just like a neurologist will use medications to do medical therapy, they can use deep brain stimulation to provide electrical therapy, and they kind of work in conjunction with each other. And the FDA has approved this statement based upon proof that this will improve quality of life for Parkinson's. So that's important in terms of when we say quality of life for brain surgery for quality of life brain surgery for Parkinson's, we're not just throwing around words. These are actually proven statements that have been approved by the FDA. So I think what's exciting is over the last few years, and especially in the last year with Medtronic's releases, is that we've known 5 years ago, I knew I was practicing DBS in the past, even though it was the present. I knew, the technology's out there. We're just waiting for the FDA to approve it, and everyone's talking about it, but we're still using the same hardware we've been using for the past 15 years. So that was kind of frustrating, actually. We knew the device worked. We knew the therapy worked, but there had been no real advances. So we've been literally stuck in the past in our present practice for a large part of the last decade. So that's what's exciting, that we're finally here now, where the present is real. What we expect to see today in 2021, we have. And that really opens the door to future advances. So I'm going to talk about that in this talk. So when talking about DBS, there are 3 keys to good outcomes. Good patient selection, that is in the hands of the neurologist. Now, I can tell you if you're a high-risk patient because you're on Coumadin, blood thinners, and that surgery may be higher risk. But whether or not DBS is going to work for somebody, that's an assessment based upon time, response to medication, and that's something that's really in the neurologist's hands. Then they refer the patient to me for good surgery, safe and accurate, and then the patient's back in the hands of the neurologist for programming. And turning on the device is done in conjunction with adjustments with medication. We know that we can significantly lower medications once DBS is on board, but all of this is done in the neurologist's environment. And I think a lot of the exciting areas with this, the new advances, are what happens in the context of programming, that third phase of deep brain stimulation. So I'm going to review those 3 steps and kind of how those 3 steps are critical to good outcomes. So patient selection, what does DBS help with? So basic insight is key in terms of what Parkinson's means for you and what medications do for you. So the primary motor symptoms of Parkinson's, what we usually think about, what the medical students learn in medical school: tremor, bradykinesia, rigidity. Also, shaking, slowness, and stiffness, right? Those are kind of the cardinal features of Parkinson's, and that's what dopamine-based medications like Sinemet help with. Over time, the problems with medical therapy become ups and downs in symptoms, so motor fluctuations are wearing off of the benefit of medicine, and dyskinesias, kind of like the squirmy side effects of medications. So those are kind of 5 features, right? The 3 cardinal features and the 2 side effects. So those are important things to kind of keep in mind as we talk about DBS and we talk about advances in DBS therapy. So this is to kind of illustrate what I'm talking about with regards to benefits and side effects. So this is a patient diary. Now, this is a banker, right? I've used this over 1,000 times, this slide, because it's so clean. But this is done by a very meticulous banker who really kind of kept track of every hour of the day. So you can see here, 7 a.m., 8 a.m., 9 a.m., midnight, breakfast, lunch, and dinner, and then the medications, Sinemet, Mirapex, and Ativan 4 times a day at the bottom. And at the bottom line, this is the off state. This is where the patient's without medication, and this is the on state where they get with medication. And many people have been seen by neurologists for Parkinson's may be familiar with the on-off testing. That's where you go to the neurologist off medication. They do a number of tests. They assign a value, a numerical value to the severity of symptoms. Then you take your medicine, you get better, and the neurologist does the same tests all over again and assign a numerical value. And that way we can quantify the medication response. So what happens over time, if you're taking diabetes pills or high blood pressure pills, you expect 24/7 control of your blood pressure, of your blood sugar. With Parkinson's, over time, that stops happening. You start having these dips. So you take medicine, you go in the on state, you're good for an hour, only an hour, and then it wears off, and you're in that off state. And you take medication again, you wait for it to kick in, and you get dyskinesias, you're off and on. So this is the roller coaster. So those are the side effects. Those are the 4th and 5th thing I talked about in the last slide: dyskinesias and motor fluctuations. That's where medications stop working as well as we'd hope, and as well as they had in the past. So motor fluctuations. So what we try to do with deep brain stimulation is capture that best response to medication and stabilize it. So you have more of this on time without the dyskinesias. So this is in a nutshell, right? Capture those best response. Usually that's tremor, stiffness, slowness, and keep you there on average 5 to 6 hours more than with medications alone. So when we see DBS after 3 months of DBS therapy, what we see is that off state without medication improves. And so that gap between on and off medicine narrows, okay? So kind of soak that in. That's a key theme that we're going to draw upon as we talk about the advances that we see with DBS therapy. So several years ago, the FDA relabeled, instead of saying, treatment of last resort or advanced Parkinson's, the FDA redefined when it's appropriate to consider DBS therapy. So to have had dopa responsive symptoms for at least 4 years, that's important because by definition, Parkinson's responds to dopamine. So if it's not clear, it becomes clear after time. So 4 years is a good amount of time to really be confident that for a neurologist that the patient they're treating with dopamine does indeed have Parkinson's disease, because that's key. If it's not Parkinson's disease, DBS is not going to work. And then at least 4 months of chasing symptoms with medication adjustments. So symptoms not controlled for at least 4 months. This is a pretty clear line in the sand to define when it's appropriate to consider DBS therapy. So that's patient selection, okay? Next is safe and accurate surgery. So once it's clear that you stand to benefit from DBS, and anybody with Parkinson's will have some benefit from DBS. It's just a question of whether medications are the same benefit or if there's other problems like balance problems or dementia, for example. So safe and accurate surgery. So in the early 1990s, DBS kind of took off. This predates a good understanding of the anatomy and visualization of the anatomy with modern contemporary medical imaging. So we weren't really using MRIs like we are now. This is a cadaver study right here. And so patients would have to be awake for surgery, and there'd be kind of a fishing expedition, check, double check, triple check, looking for the right spot for DBS therapy. Now we have MR images that really replicate what we can see anatomically, grossly, on a cadaver, we can see on an MRI. So you can see those stripes kind of similar. And this is called the globus pallidus. This is one of the targets we use for DBS. So we're able to use what we call direct targeting. We directly target the area based upon anatomy that we can visualize on MRI. So we know where to go based upon MRI. We also have intraoperative imaging. So there's the ability to get a CAT scan in the operating room is nearly ubiquitous in the United States. That wasn't the case 15 years ago, 20 years ago. So we can really take a picture and ensure that through that hole that we use for DBS, we place a lead about 4.5 inches deep. We can ensure that we're actually hitting the bullseye as we intend to, using modern surgical tools that really bring the CAT scan from the diagnostic space into the operative space. And this is how we're able to really make sure that we know where the lead is at the time of surgery. So this is kind of what we see. This is a planning station. This is what we use to plan the DBS surgery. And we can visualize at the time of surgery what that lead looks like and measure the error, see where it is anatomically, and make sure it's not far off from where we intended to be. This is the error right here. Where we wanted to be 0.5 millimeters away from where we intended to be. So to do safe and accurate surgery, we combine MR targeting with portable CT scanners to offer this operation under anesthesia. So patients are asleep versus what was standard 10, 15 years ago, where patients would have to be awake for this operation. So I do the operation with patients under anesthesia, and I find it's more consistent. We have more control over the patient's blood pressure, for example. That makes it safer. Patients are just more comfortable, and that's been my workhorse for over 5 years. By standardizing any operation, by saying these are the steps for the operation, start to finish, we really kind of make more of a consistent operation, both in the operating room and in terms of what we see after surgery. So that consistency is key, and it makes it more safe. That really kind of, when people say, what's the worst case scenario, what's the best case scenario, we want to narrow that window as much as possible so every patient gets the same outcome. And that really makes it so it puts the pressure on patient selection to ensure that as well. But we want the operation to be as consistent, get in, get out, get back in the game. And then the third step is programming, and that's back in the hands of the neurologist. So practicing in the past, right, which is what I felt I was doing 4 years ago. So pre-DBS, we've known that DBS works. We didn't know why for years, and we're still learning why DBS works as well as it does. Just the fact that it works has opened the door to investigation to further understand the Parkinson circuits, the brain circuits, and what electrical therapy does. So we knew it worked, but we didn't fully understand why, and we still don't fully understand why. With the neurologist, there's a lot of trial and error programming. We turn on a contact, we see where the side effects are, we see where benefits are, and we start trying to sort out how strong of a electrical signal we should send, how many times a second it should fire. It's trial and error. And we don't really speak the language of the brain yet. So we know the brain listens to the signal, but we don't know why. So Elon Musk, of all people, actually drew the analogy of the current version of DBS to how we used to fix bad reception on a television. So the old cathode ray tubes, right? They'd start, the image would start getting fuzzy, and you kind of just knock the side of the TV, and it would become clear again, right? And that's kind of what we're doing to the brain to kind of reset it when Parkinson starts kicking in the way that we've currently used DBS. So we basically turn it on, we leave it, and you have follow-up appointments with neurologists. Hopefully it works over the next 3 weeks. And if it's not, we can tune it up. So set it and forget it. That's Ron Popeil's line. He just died a couple weeks ago. He was the huckster on TV who would sell things you didn't know you needed until he told you needed it. So with old DBS, you set it, you forget it, knocking that TV on the side of, just like the brain to get things kind of reset. So that's kind of pre-2020. Okay. So now I've got some Medtronic slides, and I'll kind of describe them in my own way. But the BrainSense technology is what was released in June. What's key about this is the ability to listen to the brain. Okay, so not only are we sending signals into the brain like we always have, but there's also the ability to listen. And I think that's what's really key, and that's what's unique about this new therapy, is it's kind of the first step in the direction. I was just talking to a patient a few minutes ago about they asked about closed loop stimulation. What is closed loop? It means intelligent stimulation. The pacemaker is able to hear the brain and determine what kind of signal to send to the brain in response to that current brain state. We're not there yet, okay? But this technology may open the door to that down the road. But what we currently have available with this technology is a little bit different, but still kind of enhances what our options are in terms of understanding the state of the patient's Parkinson's and what therapy is doing for them. So with this, I think I'll talk about a few things. The state of the art of the hardware. So we're representing the present, where we should be right now, where we know we've been going, and being ready for the future. Okay. So this is a directional lead. So all major companies now have directional leads, meaning that if we apply some stimulation and we get some side effects over here, we get the benefit over there, we can steer the current away from where the lead is. It doesn't have to be centered on the lead itself. We can steer it around so that we can get away from side effects and toward the area of benefit. Now, all companies have the directional lead. Thank goodness Medtronic brought theirs on. That was like, come on, guys, join the club. As a surgeon, I love having that ability to steer the current. So we have that. In addition, this lead that they waited some time to introduce has the capacity for sensing. So it turns out the brain signal that we listen to is 1 million times smaller than the stimulation that we apply for DBS. And so that requires some pretty serious technology to be able to listen to the brain while applying this 1 million times stronger, sound. So you're stimulating the brain, and you want to listen to that tiny signal. And so that's some legitimate technology. So their current system is equipped to be able to listen to the brain to a signal that's 1 million times smaller than the stimulation frequency being administered. So it's the only directional lead designed for sensing. The hardware, it's a complete revamp. So they released their battery about 1 year ago, their new non-rechargeable battery that has the capacity for sensing. But now the whole system is made for this. So you have the directional lead. It's a lot more robust. So one of my reps would, they've heard this enough from me, where we'd have a bad circuit because the hardware was just not as reliable. And so they've really upped the game with the hardware. So you can twist and bend and turn it, and it doesn't short the circuit, doesn't open the circuit. The hardware, a lot of the problems about what people don't like about DBS is kind of that experience of having hardware underneath your skin, the tightness it feels with the scar tissue. So they've made more flexible leads. They've used NASA technology, whatever, for what it's worth, NASA technology in terms of kind of the insulation that they've created to send the signals from the brain to the chest where the receptor is and the degree to which it can stretch without breaking. So it's a lot nicer to handle in surgery. And I think that niceness translates into the patient experience. And then the battery itself. So it's got the batteries have the capacity to sense the brain, to listen, to receive. What's cool is the batteries will also tell you, based upon the current settings, how many more years you have. So it's less of a guessing game of patients who show up to the ER with their device dead. And so with the current, they use kind of cell phone based technology. That's your interface. You kind of hit a few buttons, you'll know how much lifetime you have. So that's a smart battery function. All devices currently have MR compatibility under certain conditions. The Medtronic one is the only one that's approved for 3 Tesla MRI. So for MRIs, for surgery, I want to get a 3 Tesla to see the target, really visualize the anatomy. And after surgery, say you have back pain and a spine doctor wants to get an MRI, they do have approval for 3 Tesla MRI. And I think what I'm going to try to get into a bit with this talk is what this digital diary is. The ability to see where your current state is in terms of on and off, using a digital diary based upon your DBS system, as opposed to the banker that I showed earlier. That you got to meticulously see, right, where am I currently in my Parkinson's symptoms, and when am I taking my medication? The digital diary, I think, is a real advance that kind of paves the way for better control and understanding of where you are currently with your Parkinson's disease, with a combination of DBS and medication. So I think the standard right now is sort of that reliable technology, the MR imaging, and I think above that, the digital diary, the smart battery, the BrainSense, I think is key. So there's an example of knowing kind of where you stand, where your battery life is, so you know when the battery is going to die. So here the battery says you have more than 2 years left, and as you get closer, you'll have a sense of which month you're going to need a replacement by. So from a surgeon point of view, the surgery stays the same, right? I don't have to, one of the things I got to be careful of is that I don't break the wire, right? So that's my job as a surgeon. And even in my hands, I've had circuit problems. So I'm glad to have more reliable hardware in my hands at the time of surgery. But besides that, besides just not having to baby this quite as much as I had to baby their previous technology, it's the same operation. So the opportunities really that are unlocked are really those opportunities that take place after the operation. So unprecedented insights. And I think the unprecedented, I was going to use this in one of my own slides. I'm like, oh, Medtronic already used it. It's really, again, to be able to understand what's going on with your Parkinson's in a way that you'd have to be a real meticulous banker to figure out otherwise. So this is a tablet. This is what the neurologist would use. And it's and you're able to kind of track this signal over the course of a month. So the neurologist can basically so the device starts listening to your brain at certain intervals. And after a couple of weeks or a month, you come back and they can see where you've been over time, how well you've been controlled. So let's go back to this slide right here. This is the patient diary of the banker, and kind of, the ups and downs, the on off. This is a patient's insight in terms of, okay, the medicines aren't working for me right now. I'm in the off state. I'm going to draw that. Here's my off state. Here I am taking medication. Here I am eating lunch. Now I'm in the on state. Oh, I'm getting better now for an hour and a half. This is all the patient. It's actually very challenging to maintain these patient diaries over periods of time. And our goal, right, is to minimize the amount of off time you have and reduce the dyskinesias. So with DBS therapy, we kind of had that sweet spot where we want to be, which is on, having our symptoms controlled without the dyskinesias, without the side effects of medication. So if you get too much medicine, too much therapy, you can rev up these dyskinesias. If you don't have enough treatment, you're going to be in that off state. And then there's that Goldilocks area, just right, where you're on, your motor symptoms are controlled, but you're not getting the side effects of medication. And to understand when that happens can inform how to better administer medication and how to tweak the DBS therapy. But with the current modalities in terms of patient diaries, again, you got to be a pretty meticulous banker to really nail these diaries. We don't really know what's going on. So it turns out, and we've known this for over 10 years, that there's a signal in the brain that we can measure that's called local field potentials. And it's this beta band, this range of frequencies that when we see this activity in the brain, this is brain activity on the right. When we see these signals, we also see Parkinson's symptoms. So we see there's a brain signal that has been robustly defined and has been tracked for over 10 years that we know if we see the signal, the Parkinson's is happening. And if we give the patient medicine, okay, give a patient medicine and the symptoms improve, that signal goes away, okay? So we know that there's a brain signal that goes up with symptoms, and when the symptoms go away, whether it be medicine or DBS, that signal goes away. That means this brain signal that we call beta, that signal can be a surrogate for patient's symptoms. So instead of looking at your symptom, like, putting a tracker on your arm and saying, oh, look, the patient's shaking right now, we can use this to track your Parkinson's state in a way that doesn't require us to observe you or have you report how you feel. Okay, so that simplifies things for the patient. Okay, so here again, we are with a typical, up and down, dyskinesias, the squirmy movements that are because of too much medicine or being off, having your symptoms controlled. We can basically find a similar measure. You can see this is the measure below, which is what's being recorded by the device, is opposite of the patient's symptoms, right? As the signal goes down, the patient does better. As the signal goes up, the patient does worse, okay? So we can measure that with the device now in a way that we couldn't before. And as we optimize treatment, we hope to, all right, see this is key, right? See the wave up here? Instead of it going, breaching into too much and breaching into too little, we stay in that Goldilocks zone, okay? So we use the information from the box to inform how to better manage the patient to keep them out of that window of dyskinesia and out of that window of no treatment into that sweet spot, which is the on state without troublesome dyskinesias, which really is the goal and what DBS has been proven to accomplish. What DBS does is it improves on average 5 hours more a day of being in that on state without troublesome dyskinesia. So when DBS was approved as a treatment for Parkinson's, it was because clinical trials demonstrated that on average, patients with DBS would gain 5 hours of on time without dyskinesias that they did not have before surgery, and that patients that continued on medicine did not have. So that's the Goldilocks spot. And so in this illustration, you're staying in that Goldilocks window of being on without dyskinesias, okay? So that's the whole goal of DBS. When I showed that banker's diary, capturing that best response to therapy and keeping it there, that's the whole goal of DBS. And that's what we're able to prove and demonstrate, not just from patients reporting it to us, but by measuring it with the new DBS system. So unprecedented insights. So you can actually see, the neurologist will be able to see what proportion of the time patients are in that desired on state. Are they in that above threshold? That's the too much. Are they below threshold, too little? Or are they in that Goldilocks? So you can actually measure based upon the patient's physiology, how much time of day they spend in that Goldilocks. So that's available through this therapy. Okay. And then here we go again. So say we want to put a little bit more input from the patient, and we want to actually correlate what we measure in the brain with what the patient is experiencing. So instead of, again, kind of trying to keep, paper, pen, or taking notes, you can use the Samsung device, the patient programmer, and you can basically just simply say, all right, right now I took my medication. Right now I'm doing well. Right now I'm squirming around, I have dyskinesias. So you can actually use this as a patient diary to create timestamps that will be registered in the device so that when the neurologist downloads the information from those 2 weeks, they can see kind of what your brain state was, and they can see times where you said, you know what, this is how I'm doing it. And you can probably hit this thing as much as you want. Too much information, I don't think so. They'll be able to correspond what you're experiencing with what they're measuring. And in response to this, the doctor can say, you know what, we have an opportunity to increase the DBS therapy. Or, I know you're taking your medications at 10 a.m. and at 1 p.m., but you can probably wait another hour with your afternoon dose, or maybe drop that dose entirely based upon what we see using the digital diary. So those are the opportunities I think that not just the neurologist has in terms of optimizing DBS, but also really informing what they should be doing with your medication. Because again, these are complementary therapies, they work together, but in many ways, there's a big opportunity to reduce or drop medications with DBS. So my patient that I'm seeing in clinic right now asked me about closed loop stimulation. We're not there yet, okay? There's not closed loop, and I don't think it's gonna, I think it's gonna be some time before we see closed loop improving upon what we already have. So just because it's new doesn't mean it's better. So we have a lot more opportunity for to understand how patients doing with DBS, I think, with this new technology. Eventually, we're hoping to reach that point where what we hear from the brain can inform how we treat the brain, okay? And so how we kind of use beta, that beta signal to determine what kind of frequency, how many times a second we fire, each time we fire, how many microseconds we fire for, and how strong we fire, right? All those parameters are things that the neurologist typically does with trial and error that hopefully by understanding the brain state, we can incorporate into the device of the future to obtain closed loop stimulation. And I think that's really important in terms of the ease with which this therapy is the experience of the patient. Is it a pain? Who has time for DBS unless you're retired or disabled, right? Versus people who want to stay in the game and don't have time for these constant appointments. I think closed loop is going to be really exciting for that. So a line I often say is, deep brain stimulation therapy is not a treatment of last resort. When we talk about the FDA saying 4 years of disease, 4 months of complications of medical therapy, it's a really clear line in the sand, and it's not where let's try everything we possibly can before we start doing deep brain. Let's make sure we try every medication under the sun that's been approved by the FDA. That's not where we are. Earlier and younger is good. We know what benefits occur with DBS, and then it's a matter of consistency and safety of surgery. It's been proven to increase the on time without dyskinesias by 5 to 6 hours. It's been proven to improve quality of life. That's where we stand. That's where I was basically 10 years ago when I started practice in terms of this therapy I had in my hand and what we're trying to make more accessible and available to patients and neurologists. The safety of the surgery and the therapy have been established. And again, think of this as a pacemaker for the brain. It's an electrical therapy that complements medical therapy that the neurologist administers, but they need a neurosurgeon to implant it. So who has time for this unless you're disabled or retired? So we are just exiting this hit the TV to make it work era. And I think a lot of what Elon Musk professes to be able to introduce as with his Neuralink company is, again, understanding that language of the brain so we can speak that language of the brain and incorporate in technology to better manage not just Parkinson's, but things like depression and Alzheimer's and other degenerative conditions of the brain. DBS works. We've known this for decades, but it's the patient's willingness to undergo this therapy that really determines whether a patient gets this. So, and that depends upon continued advances, safe and consistent surgery. So there's no, guesswork in terms of how you're going to do. If you have Parkinson's, to be able to really understand what it's going to look like after DBS, we have a pretty good idea of that right now. If the surgery was high risk, if the device was clunky and basically said, look at me, I've had brain surgery, I've got this implant, these big boxes and bumps, miniaturization is key. So what doesn't matter how successful the therapy is, if it's a coin toss, whether it works, or if it's very clunky and inconvenient for patients, they will just merely elect not to have this therapy. So that's the onus upon surgeons and industry to make this as non-cumbersome as possible. And with BrainSense, it opens the door to smarter and more efficient programming through advanced control and understanding of the patient's symptoms. So, this is like they say, name it to tame it. You got to be able to see what's going on with the patient to be able to treat it. And I think that there's new information that we're having through BrainSense that will enable the neurologist to have a better sense of where the patient is, not just at the time of their appointment, but since their last appointment, to help inform how to manage medication DBS therapy. So that's a very exciting time, and I think that we're going to see this wave of new technology really improve DBS therapy and make it more of a realistic option, appealing option for patients, more so even than it's been for the past 10 years. So I'm happy to open the door to question and answer now. Thank you.
Absolutely. And we do have quite a few questions. And if you don't mind, I'm going to stop sharing your screen so we can see everybody.
Great.
Okay, so this is incredible technology. Early on, somebody asked if Elon Musk and his company is involved in the DBS space, because the guy's everywhere. I think they're just curious just because of how incredible this technology is.
Yeah, so I think Elon Musk is incredible in terms of especially being kind of like that celebrity entrepreneur innovator, right? I mean, people had been talking about electrical cars for years, and it took somebody like him to really make it a reality. And I think the force of his interest in unlocking, let's go to Mars and let's speak the language of the brain, is huge in terms of catalyzing these advances in closed loop stimulation. I think the whole intention is to really open the door to closed loop. So he's in it. He's not sitting there publishing papers. All of this stuff is high, intellectual property, under lock and seal. And they're making like brain robots as well that they're going to use to kind of implant these arrays to listen to the brain. So it's unclear when we're going to see kind of the Tesla DBS implant, but there's a lot of money in it that's been invested, and they've recruited some really bright minds. So he's in the game. It's just we have not seen it yet at the FDA approved implantable level yet. So.
And we did have a question, if you could, because you mentioned it and just did again several times, what closed loop stimulation actually is.
Great. So closed loop stimulation, the idea, so right now, the open loop that we talk about is you got the battery, you program the battery, and it defines what's going into the brain. So one direction. Okay. So that's not a loop, right? So the neurologist programs the device and sends the therapy into the brain. Closed loop is basically where it's like intelligent stimulation. It's where they know what's going on in the brain, and that signal, the loop would be the brain sends a signal to the generator incorporates that information to decide what the brain needs and sends the signal back. That changes what's going on in the brain. So the brain's, oh, I feel better now. So we have a signal that communicates that the brain's disease is better controlled. And so all of a sudden, it's the generator may say, oh, you know what? We don't need to be as strong, or we can actually turn it off right now. And so we have less therapy. And so it's kind of this constant cycle, this loop that does not depend upon a surgeon or a neurologist to interfere with, because it's closed. It doesn't depend upon outside input. To the generator, this is how I'm doing. Generator says, okay, we'll back off. Hey, I need some help. Okay, let's up the therapy. That's the closed loop.
Awesome. So we had a few people ask about if you have the original old Medtronics leads and the new Percept battery, can you still do sensing? And they want to know also, can old leads measure the beta waves and give feedback to the new Percept neurotransmitter?
Yeah, so you can, the old leads can send signal to the new Percept battery. So you're able to listen to that. The Percept battery has some programming options that you can have as well in terms of the types of pulses that you can send. The quality of the signal that's sent through the old leads is not quite as good, but it can still be incorporated. So you can already use it for some sensing. You can pick up those beta frequencies using the old leads.
Right, because another person wanted to know if they have the older version of DBS, should it be removed and replaced with the new?
So I think that's kind of fits into the, we always want to see technology advance. We want to see improvements. Newer is not always better. This stuff has worked, and maybe what the result is that batteries last longer because you don't have to use as much power. But with a little bit more work, I think people for whom it's working, this doesn't mean it's going to be better for them. So I don't think it's worth taking out the leads from the brain and putting new leads in to get this new technology on board. DBS has always worked. It's just a matter of trying to, tie up the loose ends, clean up the edges. So no, I don't think there's a role for having the old system taken out from the brain and having a new system put in.
Okay. And then we had another question. Does continuous constant current pulses to one spot on the brain with increasing amplitude over time damage the brain?
No, so when you talk about safety, there's many aspects of safety that we consider, whether there's a brain bleed, whether putting something in the brain causes a bleed, for example, or whether there's an infection, or whether the metal is toxic, and causes side effects in some patients. So those would be safety aspects. Another question of safety has always been how the brain tolerates these frequencies of stimulation. And in fact, when we try new diseases like Alzheimer's disease, we use safe parameters for stimulation based upon the evidence that we have over decades that the brain tolerates this. So you can administer this for a lifetime and not damage the brain. So over the course of a lifetime, with tremor, for example, if you turn off the device, the tremor comes right back 20 years later. It doesn't learn. Some patients with essential tremor, not with Parkinson's, but with essential tremor, will actually turn the device off at night because there may be some tolerance that the brain develops to the stimulation. But no, the therapy. One thing somebody might think is, I want to wait until I'm a little bit worse so that DBS will help me then. The benefit it's going to give you in 10 years is going to be the same for that structure, that circuit, whether you get it in 10 years or get it now. Like, it's not going to wear off over time. The difference is that you're going to be living with the complications of Parkinson's for those 10 years in a way that might have been better had you had it done earlier.
So that's a good segue into this question. So between the time of starting the process and surgery, how long does it take? And even if I can't get the surgery now, should I start the process? And I'm going to tag on another question to this because I think it's relevant for our current state. If I'm on the waiting list for DBS, but the hospital's pausing elective surgery, which they are doing in some areas of the country, is this something that you're seeing? Can I still get the surgery?
Yeah, I mean, it's we had to shut down elective surgery back in April of last year, and I think again in January. And we're aware in Arizona that might happen again. We have not shut down elective surgery in Arizona yet. The overall process, it's never too early to think about DBS, and I think that's kind of the disconnect. It depends upon who your neurologist is too. Not all neurologists offer DBS to their patients. It's a tool for the neurologist. It's like Botox. I got medicines. These are the medicines I like. I use these. These are the medicines that are approved for Parkinson's. These are the ones I use. I use Botox. I use this. So it depends upon your neurologist whether they're offering it, because at the point you're diagnosed with Parkinson's, it's not too early to start talking about DBS. Just so you're aware of it. You don't. Doesn't mean you need it, but that's the space you're entering with this diagnosis. If you got DBS as soon as you were diagnosed with Parkinson's, it would help. God forbid you find out 2 years later that you have a different condition. You got the wrong diagnosis, right? And that's where sometimes it takes a few years to be really confident about that diagnosis. If you get DBS once you're demented, right? Say, for example, God forbid, it's going to help with your tremor. It's going to help with your movement. But that may not be the key aspect of your quality of life. Now it's the freezing. Now it's the cognitive problems. So DBS is helping with some stuff, but you got bigger problems now. So that's what kind of defines that window. But it's never too early to start talking about it. And I think that's part of the insight, knowing when you start experiencing fluctuations, that you don't have to live with motor fluctuations. You don't have to live with wearing off. I've got patients who, when they get DBS, they're taking medicine 7 times a day. They have an alarm clock every hour and a half to remind them to take medicine. You don't have to live with that. There's an option. There's an alternative to that, and that's DBS. And so it's never too early to start thinking about it, just so you're aware of it. And knowing what DBS does for you kind of forces you to kind of think about the condition in a way that gives you more insight in what's possible, both with medication and with DBS.
Okay. I had someone who asked here just a minute ago, there's nothing that's stopping their tremor. Do you think that that might make them a candidate for DBS? They've tried all kinds of medications and have had no success with it.
Yes, so that's a good caveat, actually. When I talk about that diary, I always show we want to capture your best response to medication and keep you there. Now, the caveat to that is tremor. We have patients who are tremor predominant Parkinson's for whom medications never really kind of do the trick. And in those scenarios, DBS helps. So we can do better than medications do with DBS. There's a study called a DAT scan, dopamine transporter scan, that is used, the labeling, the FDA, when they say, we approve this, they approve that to help distinguish between essential tremor and Parkinson's tremor. So you can actually see kind of the depletion in the brain associated with Parkinson's. So there's no definitive diagnosis, like there's no biomarker right now to say, all right, if we get a piece of tissue, we can diagnose Parkinson's. But we do want to make sure this is a Parkinson's disease tremor. But if it is, yes, the short answer is DBS will help with the tremor, even if it does not respond to medication, provided it's Parkinson's disease.
And they just want a clarification. The scan you were mentioning was the DAT scan.
DAT, yeah.
Okay. And then another person said, I'm 79. Is the door closing for me? I've been diagnosed since 2011, but symptoms date back to the 90s. So is there an age range cutoff?
Yeah, age range is subjective. 80 is not the same. 80 is the new 60, right, or something. So the window is closing. Whether it closes in 3 years or what, that's a matter of opinion. We do have patients in their 80s who get DBS. People even in their 60s, part of the standard is to get a neuropsychology evaluation. You see a neuropsychologist, and the neuropsychologist is going to extract some mild cognitive impairment from almost any Parkinson's patient. Even if you don't notice it, it's quite frequent that they find that. So in mid 70s, that's kind of when I started thinking with Parkinson's patients, let's maybe keep you a second night, and if you show any hesitation, let's keep that second night. A lot of patients the morning after surgery, we put the leads in, they've had bilateral both side brain surgery. They're like, I want to go home. And if they look great, they'll go home. But sometimes they'll look great the morning after surgery, and then they'll have kind of like sundowning in the evening. They're agitated, they're not eating, and their caregiver doesn't know what to do. And so I'm like, you know what, let's keep you a second night, just because once you kind of hit mid 70s, maybe there's a little bit of that kind of, all surgery has trauma, right? And when it's brain surgery, the trauma is with the brain. And oftentimes it's not noticeable at all. Sometimes it's even the cause of the honeymoon, where you actually feel better with your Parkinson's after DBS surgery. And that's from the micro trauma from surgery. And sometimes it makes the confusion, it aggravates the confusion. And that's when I say mid 70s, the recovery may be a little bit slower. You'll get to where you want to go, but you may notice some side effects, some recovery from surgery that somebody in their 60s won't have. So that's the window, you can still get surgery, but you may have more of a recovery. And I think once you're in your 80s, I want to make sure that the family's on board, that you're not doing this in a silo, that no one's calling saying, why'd you do surgery, on my 82-year-old, grandmother, that everybody's on the same page in terms of their beliefs, their values, their priorities, and their goals for therapy.
Fantastic. All right, so I'm going back to the actual surgery. One person asked, what is the difference between the awake and sleep? And another said in their area, it doesn't offer a sleep DBS surgery.
Yeah, so the kind of the direction we're going, it's not been, the FDA has labeling, and the direction we're going is to basically asking the FDA to say, you want to verify that the lead is in the right place. There's many ways to do this to verify. You can record the cells in the brain. You can check for side effects and symptoms, watching the tremor stop in surgery, or you can make sure that it's in the spot in the brain that you intended to put it. That third one is the result of the last 15, 20 years of imaging that's kind of correlated outcomes with DBS, meaning that your tremor stops, you're walking better, with where the lead's positioned in the brain. So it's reasonable now. Where we are right now is at the time of surgery, we should do something to make sure it's where we want it to be. And there's many ways to do that. You can do it with testing on an awake patient. We can do it by recording the cells, or we can do it by making sure on imaging that it's where we said we were going to put it. And all those are reasonable. So you can have bad surgery done awake. You can have bad surgery done asleep. If you pick the wrong target, it doesn't matter how accurate you are. You're not going to get the results you're hoping for. You got to know how to pick the target. You got to have good quality imaging. That's where my focus goes, doing a sleep surgery. So you get great surgeons and great surgeries, either modality, and it largely becomes surgeon preference. And then individually as a patient, if you come to me asking for a awake surgery, I'm going to be like, well, I do much better. I know where I stand at the end of an operation with a patient asleep using my intraoperative imaging, right? And I'm less likely to make a dramatic change based upon awake feedback than an awake surgeon might, who's saying, oh, you know what, you're feeling a little tingling, let's move the lead anterior. So we use these tools to determine repositioning. Do we need to reposition the lead? It's great if we, first shot, we nail it, right? But the use of awake technique is to inform repositioning of the lead, to tell me at the time of the surgery, it's not in the sweet spot yet, and I need to reposition it. And that can be done awake or asleep. But that's basically, if we just put it, it's a perfect location, great. It's to tell us that we're not in the right location and to inform moving of the lead left, right, front and back.
Fantastic. So we had a question earlier. They want to know how long is the downtime in recovery where they can get back to exercise?
I say so exercise, if you want to go for a walk, go on a walk the day after surgery, just don't fall, right? If you have a history of falls, if you fall before surgery, it's your Parkinson's. If you fall after surgery, it's because you're recovering from surgery and you fell, and that's not good. But no, you can start going on walks immediately. You can probably do a exercise bike if you wanted. The surgery is done in 2 stages. You get the leads, the wires in the brain, then you get the battery 2 weeks later. And about 4 weeks after the battery, so 6 weeks after the brain surgery, is kind of when I say use common sense, but you can do whatever you want. You don't have to think about the wounds anymore. You kind of know where your brain has kind of settled, and you can do whatever you want. So the short answer would be 6 weeks from the beginning is when you can start swimming again, and breaking a real sweat, doing range of motion, right? Usually by the time I see a patient 4 weeks, 2 weeks after the battery, all I'm really worried about when they talk about exercise is range of motion with that shoulder, because I don't want them to be pulling and applying stress to that scar that's healing. That's all I'm worried about at that point, really, is range of motion with the shoulder on the side where the battery is. So short answer is 6 weeks after the whole thing starts.
Fantastic. And I had a question of how many programs does it typically take to get all the settings correct?
So I'd say probably about 4 to 6. It can take about 6 months, 3 to 6 months to optimize this. It's at the neurologist's discretion. There's an art in terms of programming. A roller coaster would be where you drop medicine completely and you're suffering, and then they try to build you back up with DBS and see how much they can get out of DBS, and then they start introducing medication back. That would be a roller coaster. You don't want that. So instead, what you end up doing is you take 2 steps forward, you get the DBS going, and then 1 step back, they drop the medication, then 2 steps forward, 1 step back. And so gradual improvements. So you're not dealing with the withdrawal of medication. You're not feeling like the slowness, the depression from the medication being withdrawn so quickly. So again, the short answer there would be maybe 4 to 6 programmings, about 3 to 6 months, and then tune-ups, on an annual basis thereafter.
And one person asked, how long does DBS work? Theoretically, does it always work to control the motor fluctuations?
Yeah, it'll work the rest of your life.
Okay.
It'll always help with the motor fluctuations. It'll always help with the dyskinesias. it'll always help with the stiffness, the slowness, and the tremor. And that's why if it were not to work like that, then you could have the argument, you know what, I'm going to wait 7 years so it helps me 10 years from now. Because if it only worked for 10 years, then you might want to wait until later. Because we know it works the rest of your life, the timing that's not a factor in terms of timing.
Right. You just adjust it as time goes on.
You can adjust it. Yeah. Yeah. One of the nice things about DBS is it's an implant in the brain, but it's non-destructive. You're not destroying the brain. It replaces ablative procedures that actually destroy the brain, create a stroke in the brain. So it's adjustable, it's reversible, and it's non-destructive. And those are key features.
Right. And a question earlier came up, is this BrainSense clinically available, or is it still being launched?
It's out. Yeah, it's available now. So since the leads were released in June, it's out. Keep in mind, it's not closed loop stimulation. So it's a tool for the and it becomes a tool for the neurologist to incorporate into their practice in terms of factoring in the beta signals, the digital diary, things like that, to better optimize the therapy and the medications.
And one of our participants, Rogers out there, shared his experience. He's recently had DBS implanted, and he was saying that when he turns his DBS off in about 27 minutes, his tremors are in full force, but it only takes 10 seconds to remove the tremors when his DBS is turned on. So that's pretty significant.
That's great. Yeah, I keep getting his thumbs up, so that's good to see.
Yes, that's Roger giving you the thumbs up. Fantastic. All right, well, we have a question for time for about one more question. And I guess this was a good one. Does Parkinson's extend recovery time for any type of surgery? They've had DBS.
Oh, this Parkinson's, sorry, is DBS part of that or not? Is it just Parkinson's?
It says, does Parkinson's extend recovery time for any type of surgery?
Yes, it does. I'll just speak from my own familiarity. We know in spine surgery, and it's almost like it's our go-to now at our conferences. Parkinson's patient, our head of spine says Parkinson's and spine surgery is like oil and water; they don't mix. Because with neurosurgery we do brain and spine. And our Parkinson's patients have a tougher time with spine surgery.
Awesome. And do you find that it's harder for some to recover from anesthesia?
The anesthesia is a factor too. I think it kind of can result in some decompensation. Patients who have mild cognitive impairment that the neuropsychologist measures, but they may not experience day to day. They may have, because they're able to compensate for it, there may be some decompensation that occurs because of general anesthesia.
Awesome. All right. Well, we are out of time. This has been fantastic information. We really appreciate your time, Dr. Ponce. I really appreciate everybody joining us today. If you could all turn on your screens if you're not already on, and give the wave of gratitude to Dr. Ponce and to Medtronic for giving us this great information today. We thank you for joining us.
Thank you very much.
All right. Thank you. Bye-bye.